I'll let you find a seat, and we'll start very, very shortly. On time. So my name is Marie-France Langlois. I'm an endocrinologist at the University of Sherbrooke in Quebec, and I'm co-chairing this session with Geeta Achutan, just here, from a family physician from Regina, Saskatchewan. And we have a very exciting session this morning. We'll start with personal perspectives, like we do usually in our sessions at the Obesity Summit. And then we'll have 3 talks. Talks will be 15 minutes with 5 minutes of questions at the end. So we'll have questions after each talk. Okay, so it's a pleasure for me to present to you Lisa Schaefer. Lisa, you saw her yesterday night at the opening ceremonies. She's chair of the Obesity Canada Public Engagement Committee. She's a sales and marketing director living in Vancouver and very active in her daily life. And please join me in welcoming her.
Good morning. I'm back. So thank you. I really appreciate being able to share my patient story with you this morning. I need a clicker. Did the clicker move? Does anyone know where the clicker is?
Oh. Sorry.
Did you steal the clicker too?
Two.
Man. Brilliant. All right. So let's start over. Okay, I'm excited to share my patient story with you this morning. For the next few moments, I'll share a bit about my experiences as one of the millions of Canadians that lives with obesity. As has already been mentioned, I am a member of the Public Engagement Committee for Obesity Canada. And as Dr. Sharma remarked last night at the opening ceremony, one of the true strengths of Obesity Canada is that it truly is a patient-centered organization, and it recognizes the value of stories like mine. So to get us started, I wanted to share some more insights about me. Personally, I have a fantastic family that taught me the value of community, and as a result, I have an amazing village of friends and family. I know I'm a good friend. I've been a bridesmaid more than 4 times in my life, and I have a really great life with my partner, Dean. Professionally, I'm a director of business development for an international marketing agency. That sounds really fancy, but it's not. My job is, however, fast-paced, it's challenging, and I truly love it. I'm a marketer, I'm a relationship builder, and I'm a leader in my organization. My personal passions, those things that make us uniquely us. I fancy myself a bit of a maker. I taught myself how to sew at the age of 42. Don't do it. My grandma taught me how to make amazing cookies at the age of 5. And fitness for me is a form of self-care. Time outside, especially I live in Vancouver, out in the woods, is absolutely amazing for me. And as Plato said, those who tell the stories rule the world. So I fancy myself a bit of a raconteur and an advocate. But another word can be used to describe me, and it is a word that has followed me my whole life. And that word is fat. Fat. 3 little letters that have had a huge impact on my life. Fat has been my constant companion on my life's journey, and it has taken me years to realize what it truly is. Seeing my weight as anything but a moral failing on my part has only come in the last few years. And to be fair, it still requires a very concerted effort. How could it not? Our society is pervasive with messaging that anything to do with fat is bad. Making the connection has truly been a journey for me, and while I could tell you many, many interesting stories, I've decided to share just a few with you today to really speak to some pivot points in my life. Essentially, this will be the tale of me moving from being blissfully unaware to painfully aware to aware and empowered. So we'll start at the very beginning. Childhood, where we all start out blissfully unaware of the twisty nature of life. My story is not unlike many people. I grew up in Edmonton during the late 70s and early 80s, a magical time to be alive where more and more plastic foods were being produced, and my parents would sign up willingly for anything that was new and exciting. My parents were loving and generous, and they did the best they could with what they knew. But I was potty trained using Smarties, so let's be honest, that lays a track. Food was love in my house. If you had a bad day, food was offered as comfort. If you had a good day, food was offered in celebration. I loved school. I was involved in dance. I still own tap shoes. And for the most part, I was happy. But I was fat. I was the fattest kid at school, and I was reminded of that daily. When I was 10, we moved from Alberta to BC, and I remember being absolutely terrified. I was cloaked in shame. Shame about my body at the age of 10. Shame is brutal. And looking back, I can see now that the shame I felt about being me, about my body, was overwhelming. I truly, with every ounce of my being, felt awful about myself and my inability to not be fat. I felt like I was an unsolvable problem more than I felt like a person. I was repeatedly tested for prediabetes, diabetes, PCOS, sleep apnea. Something has to be the cause of this. And yet I had no comorbidity to take the blame. So at a very young age, I was left with the impression that I was the problem and that this was of my very own making and mine to dig out from. At 12, I begged my mother to buy me Deal a Meal. Richard Simmons was my hope. Deal a Meal did not save my life. We then move into the next phase of my life where I became painfully aware of the twisty nature of life. Again, for the most part, I was happy. I met with success and failures professionally and personally. I kissed some boys, I had some fun, but I found out more about myself, and my life started to look different, but I did not. I was still a problem. I still carried this pile of shame about my weight and about myself. Sadly, the shame was often reinforced by people around me, often in that nice backhanded compliment kind of way. The classic, "You have such a pretty face." When I finally worked up the nerve to talk to my doc about it, my GP told me not to worry about it because I wore my weight well. I still don't understand what that means. A pivotal moment came for me when I realized that even in my 30s, my weight overshadowed my professional efforts and my accomplishments. At this point, I was a very busy sales executive at a very high-profile company. I managed several accounts, and one of the managers of an account that I had just done a major install for was very pleased with the work that I had done and felt moved to call my boss, which was lovely. Most people don't do that. We only call when we have complaints. But sadly, this wasn't just a call about a job well done. He called to compliment my boss for hiring me in the first place. He said, "For someone that looks like she should be working in the back of the kitchen as a line cook, she did an outstanding job." Pretty awesome. And the fact that my manager felt that it was okay to repeat that to me verbatim still blows my mind. I felt doomed to only be seen as, first and foremost, the fat girl. That really pissed me off. So I decided to do some things about that. At this point, I made myself motivated, and it was not just about to lose the weight, but to better show up for myself, to better stand up for myself. I learned about assertive rights, and it was pretty empowering. I dialed into my health instead of focusing on food, and I found a community of like-minded women in Vancouver. Big, athletic, badass women, and this was a total game changer for me. Weight be damned, I began running, hiking, I tried yoga, I do kickboxing, you name it, I was up for trying it. I have climbed some pretty awesome mountains, and I have surfed some pretty amazing waves. If you ever get a chance to go to Tofino, do it. I fell in love with my life, even though my weight persisted. And I wasn't alone. I found a community of people who were out there living with obesity and kicking ass and focusing on health, but still the bias follows us. I often run in Vancouver on the seawall, if you're familiar with it. And I love running on the seawall. It's one of my favorite things to do. But almost every time I go out and run on the seawall, people stop and will clap for me. And I know their intent is pure, but it's really damning to feel like I'm being complimented for finally taking care of my health, or that I am, somehow like a child learning to use the potty. It's really frustrating. I was once even in an 8K race wearing my bib, and a marshal came over and told me to step aside to let the real runners go past. I'm like, I paid money to run on the street, what? Didn't make sense to me. It was during this time that I came across my first practitioner presenting obesity as a disease. I was a master of ceremonies at an amazing event called Platform for Plus Size, and I heard Dr. Ali Zettner speak. This was unlike anything I'd ever experienced before. She spoke of her personal experience And she talked about weight, but above all, she framed it as a disease, something worthy of time and attention. And that broke my brain. I then started working with Allie and began educating myself on the disease of obesity and the treatment options that were available in front of me. I was very hesitant of surgery for a myriad of reasons, but she convinced me that there was no harm in going on a wait list. And sure enough, 2.5 years later, my name came up on that list. And after much more consideration, I moved forward and ultimately pursued the option of doing a gastric sleeve in 2015. Now, I would love to say that I lived happily ever after from that moment, that it was my magical bullet, but that would be a lie. Remember, life will continue to be twisty and cruel, but when we're empowered and aware, we can say, I see you, life, and I know that you're going to continue to be bumpy, but you scare me a little less, because I have some new tools in my toolkit. 4 years out, I'm now experiencing regain, and while I do have a better understanding and insight, and better skills to navigate life as a person living with obesity, challenges persist. Stigma and bias persist. As someone who has had their one chance at surgery but still not met with success, my treatment options feel even more limited and even further out of reach for me. The few options that are available are very expensive, and they're not covered by my basic or extended medical. I'm often found bringing information to my doc. Luckily, I have an amazing family doc who is willing to engage in these conversations with me, but I find it fascinating that I'm the one that has to bring these information pieces to her and point her to places where she can get better educated. We can do so much better. And that's why I'm here today, and that's why I advocate for the much needed change around the understanding and treatment of obesity. We absolutely need to reframe our view of obesity and treat it with the respect, dignity, and resources given to other chronic diseases in Canada. This is where you come in. We need your help. We need your voice. We need you to help us check for bias. It can be little things like having the right size cuff in your practice, like having a chair that doesn't terrify us when we walk in the room. There are lots of little things that are inexpensive that we can do to make a big difference for the millions of people that live with obesity who are trying to show up for themselves, who are trying to be empowered and aware of their life. The other thing that we would ask you to do is support Obesity Canada. We have a newsletter. Sign up for it. Shout out when you see our social posts or when we're putting forward new and exciting information. And use your voice. Call out bias. Call out stigma when you see it. And if at all possible, please go to our website and click the link on the report card. It's 3 buttons, and it'll send out some messages to some really important people. We're going to go knock on doors on Monday on Parliament Hill, and I would love to be able for them to go, I've heard of you. I knew you were coming to see me. So those are the small ways that you can get involved, but being here is a huge part of it. So thank you for being here. I hope you have an amazing time at the summit. And that's the story of Lisa.
Thank you so much, Lisa. We have a few minutes for questions if anyone has any. No? No questions? Yeah. Thank you so very much, Lisa. Our next speaker is Dr. Sue Pederson from Calgary. Dr. Pederson is a certified American Board of Obesity Medicine diplomat and a specialist in endocrinology and metabolism in Calgary. She's the lead author of the Pharmacotherapy chapter of the 2019 Canadian Obesity Clinical Practice Guidelines. So please join me in welcoming Dr. Pederson.
Wonderful. Good morning, everybody. And first of all, I'd like to thank Obesity Canada for inviting me here today. And on behalf of myself and my co-authors, Priya Manjoo and Wharton, we're very excited to share with you a sneak peek of the Pharmacotherapy chapter of the Canadian Obesity Guidelines. Because it is not yet published, we're not able to share with you the official specific recommendations, but we will go through a lot of the information that is contained within our chapter. And as we go along, I will also point out some of the key messages that we will have as part of the guidelines chapter. My disclosures relate to the fact that I'm the principal investigator in our clinical trial program at my office at CENDO in Calgary, type 2 diabetes, obesity, and type 1 diabetes studies. I'm also a member of several advisory boards, and I'm very involved in continuing medical education. First of all, I would like to just describe to you the methodology that we undertake in creating these guidelines. And actually, we really parallel what is done when we write the Diabetes Canada guidelines, which is a very rigorous process. So first of all, we generate specific research questions, which are generated to inform us on pharmacotherapy studies published since the last obesity guidelines were published in Canada, which was in 2006. We included only randomized control trials or meta-analyses of at least 6 months duration. And these were studies where there was a weight parameter as a primary endpoint. And just to make a point that we actually opened up our search to all prescription medication in Canada. So any study that fit this criteria that is a medication that can be prescribed in Canada was included in our literature search. There was then a systematic literature review undertaken, and that is done using distiller software with McMaster University. They then generate the article collection for us, give them back to us, and then we go through them one by one, and it is on that basis that we develop the guidelines and the recommendations. So, why should we use pharmacotherapy to treat obesity? Well, we know that a clinically significant weight loss, which we define as 5 to 10%, because this improves health complications related to obesity, is what our goal is to try to obtain, but this is very difficult to do with health behavior change alone. That we know that health change, behavior change, generally only achieves a very small amount of weight loss, and if it does provide some weight loss, a really important point is that this is very difficult to sustain over the long term. Therefore, pharmacotherapy should be considered to decrease weight and improve metabolic parameters when health behavior change alone has been ineffective, insufficient, or without sustained benefit. Pharmacotherapy indication in Canada for chronic weight management is for individuals with a BMI of 30 or greater, or a BMI of 27 or greater with a comorbidity associated with excess adiposity. And examples of that include type 2 diabetes, hypertension, dyslipidemia, etc. So this is one of our key messages, that when we are choosing the appropriate medication for our patient, there's a number of different factors that we need to consider. So what is the mechanism of action of the medication we're thinking about? What are the side effect potential, tolerability profiles, safety? What comorbidities does my patient have where I might want to choose a particular medication because I know that that will improve that particular comorbidity? What existing medications is my patient taking? Are there any drug interactions I need to think about? What is the mode or frequency of administration? Is it oral? Is it subcutaneous? How many times a day is my patient, would they need to take this medication? And engaging the patient in that decision-making process. What would my patient like to do? What kind of medication administration are they interested in? Cost, of course, is a very real concern for obesity pharmacotherapy. Only about 20% of private medical plans in Canada cover pharmacotherapy, and there is no public reimbursement, so that's a very real issue. Key message, there are 3 medications approved as pharmacotherapy for obesity in Canada, and these are listed in the order in which they were approved in Canada. So orlistat was approved in 1999. This is a tablet, 120 milligrams, 3 times a day, taken with meals. It is a pancreatic lipase inhibitor, so what it does is it decreases fat absorption when we eat fat. The cost is approximately $200 a month, just under that, depending on the pharmacy, of course. Liraglutide, 3 milligrams, was approved in 2015. It was actually also available in Canada since 2010 as a diabetes medication at a lower dose of 1.8 milligrams. This is a medication that is actually 97% analogous or identical to the human hormone called GLP-1. This is a hormone that is released by our intestines when we eat, and it acts as a satiety signal in our brain. It is dosed 3 milligrams subcutaneously once a day, and the cost is roughly $450 a month. Naltrexone bupropion is a combination of two medications that have both been available for over 20 years, but was approved as a combination tablet for obesity in 2018 in Canada. Naltrexone is an opioid antagonist that has been in use to treat opioid and alcohol addiction. Bupropion is an antidepressant medication and smoking cessation agent that decreases the reuptake of dopamine and norepinephrine. It also acts centrally to induce satiety and also decreases cravings. This is 2 tablets twice a day, so 16 milligrams of naltrexone, 180 milligrams of bupropion twice daily, and the cost here is approximately $300 per month. Now, in terms of weight loss, the data that you see here is the highest level of data that was generated by our distiller analysis. Orlistat provides a placebo, so these are all placebo-subtracted weight loss over 1 year. Orlistat provides a 2.9% placebo-subtracted weight loss, liraglutide 5.4%, naltrexone bupropion 4.8%. Now, we're not just interested in what is the average weight loss, but we want to know what proportion of my patients can achieve a clinically significant weight loss, which we define as 5%, or to get more than also 10%. And in the interest of time, I'm not going to go through all of these numbers, but you can see them here on the screen. The point being that all of these medications, on any of these medications, there is a greater proportion of patients that will achieve a clinically significant weight loss compared to placebo. In terms of side effects, for orlistat, because it decreases fat absorption, that can cause loose or oily stools or flatus, gas. Rare side effects that have been reported include liver failure. It increases urinary oxalate excretion, I should say. Therefore, there have been case reports of kidney stones and acute kidney injury. Liraglutide 3 milligrams transiently slows gastric emptying. For most people, that's a transient effect. Some people get side effects related to that, which can include nausea, constipation, can cause diarrhea, can cause vomiting. And in terms of rare side effects, a very low risk of pancreatitis and also a low risk of gallstones. Naltrexone bupropion side effect profile is related to the side effects that are well known with each individual component of this combination medication. That can include nausea, constipation, headache, dry mouth, dizziness, diarrhea. And rare side effects that have been reported with bupropion in the past include very low risk of seizure, and any antidepressant medication can transiently worsen depression. Now, in terms of contraindications and drug interactions, in the interest of time, I'm not able to go through each of these in detail with you today. One thing I will point out is that pregnancy and breastfeeding are contraindications to all anti-obesity pharmacotherapy. And when we're thinking about prescribing a new medication, we always very important to look at potential drug interactions. Key message. Pharmacotherapy is not only a useful tool to help our patients lose weight, but can also be a very useful tool to help patients lose weight or maintain weight after they have already had some success with health behavior change. So the message is that it can be used to maintain weight loss achieved with prior health behavior change. There are data for orlistat and liraglutide in this regard. Orlistat has been shown after an 8-week, very low-calorie diet that it results in less weight regain after that lifestyle-induced weight loss. 4.6 kilos weight gain with orlistat versus 7 kilos on placebo, and that was at 3 years. There is also data on liraglutide in this regard, and this was a study where patients were helped to lose weight with a low-calorie diet. They lost an average of 6% weight, were then randomized to liraglutide or placebo, and it was found that not only did patients in the liraglutide group have a greater likelihood of maintaining that dietary-induced weight loss, but they actually lost an average of another 6%. So on basis of these data, we have this key message. Now, we're not just interested in numbers on the scale. What we're especially interested in is improving the health complications of obesity that our patients may carry. So we had some specific questions looking into the effect of obesity pharmacotherapy on comorbidities of obesity. Prediabetes is a very important time to be able to intervene to try to prevent development of type 2 diabetes. And orlistat has been shown to result in a 37% reduction in the risk of developing type 2 diabetes over 4 years. Liraglutide 3 milligrams has been shown to reduce the risk of developing type 2 diabetes, again in a population with prediabetes, by 79% over 3 years. All of these medications have been shown to reduce hemoglobin A1C in patients with existing type 2 diabetes. Liraglutide is more effective. Again, these are not head-to-head comparisons, and I should point out that none of these, in any of these data, are head-to-head. No pharmacotherapy trials have been done looking at these medications head-to-head. These are individual sets of data. But liraglutide is also a diabetes treatment. It has an effect on the hormones that are produced by the pancreas, including insulin and glucagon. Therefore, we are not surprised to see that it is more powerful from a diabetes prevention or treatment perspective. In terms of other cardiovascular health risks, again, in the interest of time, I'm not going to go through all of this, but of course, we're interested in CV risk parameters. There is a small improvement in blood pressure with liraglutide, also orlistat. Naltrexone actually attenuates the blood pressure reduction that is seen with weight loss because it is an adrenergic agent. And there is some improvement in lipids in all 3 medications as well. In our literature search, we pre-specified these 4 comorbidities as well: non-alcoholic steatohepatitis, or NASH, polycystic ovary syndrome, osteoarthritis, and obstructive sleep apnea. As you can see, there's many areas here where there are some gaps in knowledge, where each particular medication has not been studied specifically in these subgroups. Things of note are that in non-alcoholic steatohepatitis, liraglutide 3 milligrams has shown an improvement in a small study. Orlistat had a study done showing no improvement. And the other one I'll point out is obstructive sleep apnea, has been specifically studied with liraglutide 3 milligrams and has been shown to reduce the apnea-hypopnea index by 6 events per hour. So when should we stop pharmacotherapy for obesity? So we get asked this a lot, right? We get asked by our colleagues, we get asked by our patients, how long should I take medication to treat obesity? And what we would encourage is thinking about obesity similarly to how we think about treating diabetes or treating hypertension. This is a chronic disease needing chronic treatment. Pharmacotherapy for obesity is intended to be part of a long-term treatment strategy. That being said, of course, if our patient is having side effects that can't be managed, not tolerating the medication, that's of course a reason to stop pharmacotherapy. There's also a stopping rule that is in the product monographs, which is advised by Health Canada, which says that if our patient does not achieve a clinically significant weight loss of 5% after 3 months on the full or maximally tolerated dose, we should stop pharmacotherapy. But what we recommend is thinking about what was this patient's weight trajectory before they started pharmacotherapy. If they had lost weight with health behavior change and have now maintained that weight, have not regained as they perhaps had historically done in the past, we consider that a success of pharmacotherapy. If the patient had been gaining weight on a weight upwards trajectory and is now weight stable on pharmacotherapy, we would consider that a success of treatment. So we need to look and see where is my patient coming from before we can decide if this is a success or not. We also want to think about what factors could be impairing our patient's weight loss effort. Perhaps they've had some emotional upheaval in their life since they started pharmacotherapy for other reasons unrelated, and now they are having trouble managing their hedonic or emotional eating, and maybe that has interfered with the optimum success. So we need to think about these things rather than just look at the numbers to decide, has this been a successful treatment strategy or not? Now, if we've gone through that and we determine that our patient actually has not had success, a key message is that the response to pharmacotherapy is heterogeneous amongst patients with obesity. So if one medication is not working, we could certainly consider stopping it and trying a different medication instead. And this will be my final point for today, and this again is one of our key messages. Remember that, as I mentioned to you, we opened our literature search to all prescription medications in Canada to look to see if there was sufficient data to recommend any prescription medication for weight management. There is insufficient evidence based on our literature review to support use of any other pharmacotherapies or hormonal treatments that are not indicated for chronic weight management. So there's a lot of hormones and such sort of things being prescribed. There is insufficient data for any of these treatments, and they should not be utilized. And with that, I will close the sneak peek to the pharmacotherapy chapter, and I would like to thank you very much for your time, and I think we have a few minutes for questions.
Thank you, Sue. So I invite you to come to the microphones for questions. Don't be shy. And please state your name and where you come from.
Hi, I'm Dana Liang from Toronto. Thank you so much. That was a great review. I just wanted to ask about the age range of the studies that you looked at, because as you know, the demographics are increasing in terms of age, and so I'm wondering whether you feel that these drugs are safe in patients who are older than 65 and maybe into their 70s even, who want to lose weight.
That's a great question. So these were all adult studies, just to point that out. The data for weight loss for orlistat was actually a meta-analysis, whereas the liraglutide and naltrexone bupropion study data that I quoted were the singular largest studies with weight loss as a primary endpoint at 1 year. The age range for those studies, off the top of my head, I have to go back and look to see what the upper, I don't think there was an upper age range, but I don't recall that off the top of my head, so I have to go back and look at that. As far as whether there's an upper age limit to obesity pharmacotherapy, I would say no. Certainly, as patients get older, there is something called the obesity paradox, which we're probably all familiar with in this room, that in people who are older, people with certain chronic diseases, it can actually be advantageous to carry a little extra weight because there's actually better survival. Because simply put, if someone were to get sick and lose 30 pounds, if you carry a little extra weight, you're more likely to survive that. So I think that our clinical practice is such that as patients get older and become elderly, that we perhaps have different weight management goals towards maybe carrying a little bit more generous weight. But I would not have an upper limit at which I would restrict pharmacotherapy at all.
No more questions? Thank you. Thank you.
Thank you.
So now we'll move to real-life experience in using this pharmacotherapy. And with us, we have Dr. Sean Wharton. Dr. Wharton is the medical director of the Wharton Medical Clinic, a community-based internal medicine, weight management, and diabetes clinic. He's also an adjunct professor at McMaster University in Hamilton and York University in Toronto. So please join me in welcoming Dr. Wharton.
Thanks a lot, guys. This is terrific. I think right away we'll address the fact that this room does not make any sense when it comes to presentations, right? I mean, everyone can see that. So what I'm going to do is I'm going to start over here. Is the microphone working, right? It is? Okay, great. We'll start over here. So what I've been charged to do is to give you a little bit of an example of the real-world experiences with this pharmacotherapy. So the question is we've got randomized clinical trials, and there's a perfect situation there. And you're getting phone calls from the researchers. You're getting the medication free. There's a lot of good things happening in the randomized clinical trial. But the question is in the real world, where you have to pay for the medication, where there's other challenges within your life, is it going to actually work as well as in the randomized clinical trial? So what we're going to look at is, so here are the disclosures that I have here, and you can read them out. So the real-world evidence is becoming a more important factor for us. So we can see here that it's changing the way we study safety and the effectiveness. In the US Congress has defined real-world evidence as data regarding the usage or the potential benefits or risk of a drug derived from sources other than a traditional clinical trial. So in the 21st Century Cures Act of 2016, we're going to be using real-world data to support decision-making, including approval of new indications for approved drugs. We're going to be looking at it for healthcare decisions, monitor safety and adverse effects, to support coverage for these medications that are a big challenge, developing guidelines, decisions, and also supporting new clinical trials. What are we going to look at for clinical trials? Large-scale ones, simple ones, pragmatic ones. And so the question is here in Canada, do we have any anti-obesity real-world evidence? Like, is the medication working the way it should in this patient population here? So what we're going to look at is some data that comes out of my clinic. So I run the Wharton Medical Clinic. There's 6 bariatric clinics. The data that I'm going to show you is from the time that I had 6 clinics. I now have 4 clinics, and I'm much happier with 4 clinics and 6. 6 was a challenge. So government funded, the patients do not pay to come to the clinic. There are 20 internal medicine doctors working, a number of multidisciplinary staff, and the research staff that really makes a lot of this happen. Elham Kamran is right here, my research coordinator, who helps me to coordinate all of this. So here are the locations of the 6 clinics across the province, and we get 1,000 new patients every month. So the data comes from all of these new patients and also the existing patients, about 5,000 patient visits every single month. And it's a multidisciplinary, the patient-centered to a large extent. We have an adult clinic, pediatric clinic, a pre- and post-bariatric surgery clinic, and referral to CBT and food addiction clinics. But the big deal is this, the informed consent. Every patient signs an informed consent, because I can't show you this data and I can't publish it if they haven't signed this informed consent form that goes to my researcher, Jennifer Cook, who's a PhD out of York, and we collate all this information, and then we're able to actually publish it. Okay, so this is how we collect it. Every patient that comes in, we ask who is on a medication. We ask them which medication you're taking. It's collected by the bariatric educators. And you can see here that in the medication list, it's not just Xenical, Saxenda, and Contrave. We also collect information on Ozempic, off-label, because we use it. We also collect metformin due to psychiatric medications that cause weight gain. We use that, and we collect the data on that. So when did you get your script? What dose was it at? Is it full dose, half dose? What are you taking? Beneficial effects in your own words. What's it doing for you? Side effects. And are you taking it? Are you taking it regularly? Are you missing doses? Are you missing doses because it costs too much? What's going on? Do you have coverage? And are you in the Contrave support program or the Saxenda? The Saxenda Care. And we're publishing on Saxenda Care. It's not around anymore, so we don't have it as one of the major questions. So here are the medications in Canada. And let's start with Orlistat. So the data on Orlistat is that the clinical trials that got approval by FDA and Health Canada showed about an 11.4 kilo or 11.4% decrease in weight in the first year. That's a lot of weight loss. This is back in the 1990s. I don't know how they did that, but that's what happened. So the question is in the real world, are we going to see an 11.4% decrease in weight over the first year with this medication. What we really actually do see when we look at meta-analysis, it's about a 3% placebo-subtracted weight loss in orlistat. Whenever we talk about placebo-subtracted, if you're looking at what the patient's going to actually have, you have to add the placebo component to it. The placebo component is always 3%. So add 3% to whatever your placebo-subtracted is. Placebo-subtracted was 5.4%. Add another 3, that's about what your patient's going to see, about an 8% decrease in weight. Here it's 3 plus 3, about a 6% decrease in weight is what we actually see. So what happened? Unfortunately, there's no real-world data on orlistat, which is unfortunate, but so we decided to collect our own data. So we looked at 516 patients, we asked them, have you taken orlistat? And this is retrospectively. They had to remember whether they had taken it previously. So out of the 516 patients that we consecutively, they came to the clinic over a week time, we just gave them a questionnaire and said, have you ever taken it? So 9% of people had ever taken the medication. Out of the 9% that actually took it, we asked them, did you lose weight while taking it? Half of them said, yes, I actually lost weight on it, which is good. And side effects, what side effects did you end up getting? About 68% of patients said we got side effects from it. Which side effects? Number one side effect, no surprise here, diarrhea was the number one side effect. Oily stools was after that. Orange stools was there next. Why did you stop it? Because they aren't on it now. The people who answered the questionnaire, side effects was the number one. It stopped working. It's different from it didn't work in the first place. So those were some of the reasons there. And this is the big one here. Did it work? Did you lose weight on it? And how long were you on it? So the patients on average said they were on it for 7.8 months. Is that your experience with orlistat? That's a long time. That's pretty impressive. And they also said that they lost 30 pounds. That's about 13 kilos. That's about a 13%. So are we getting close to what the clinical trials showed? About that, right? So the winners, the people who stayed on it, which is a small number of people, actually do well on it, which is kind of interesting, right? So now let's look at liraglutide. This is the biggest real-world study that we've done. So in the randomized clinical trial, what we see is about a 8.4 kilo decrease in weight, right? So around that 8% range. The completers getting to about 9.2%. So the question is in the real world, can I get to that 8%, 9% decrease in weight, right? Whether you have to pay for the medication yourself, there's challenges at home, et cetera, et cetera. So this is the study. We looked at 850 patients. Out of the 850 patients given a script for the medication, 311 patients filled it or started taking the medication. By the time we got to 4 months, 210 patients are still taking it. By the time we get to 6 months, 167 patients are still taking it. So 53% of the patients are still taking the medication at 6 months' time. That means 47% of them stopped. Sounds like a lot, right? Do you know the number of people that actually stopped coming to a weight management clinic at month 3? It's about 80% of people. So the fact that 53% of people are still at my clinic and still taking the medication is a big deal. It means that something's working, as opposed to the 20% that would normally be there. Okay, so the next question is, who were these patients? They were 50-year-old white females mainly, and their weight was a little bit higher. Their BMI was about 40.7. In the clinical trials, it was about 38. So they're about 114 kilos. The weight down there, it's about 100 kilos that we usually see in most trials. So they were a little bit bigger. And did it work? Did they lose weight? Over the 4-month time frame, we see that there was about a 6.2% decrease in weight. And over 6 months, a 7.1%. So the question is, are we getting close to what the RCT showed, about an 8% decrease in weight? 7.1% decrease in weight for those staying on it up to the 6-month time frame. All patients, those who stopped and those who stayed on it for 6 months, about a 6.6% decrease in weight. Categorical weight loss. How many people lost 5%? This is part of the FDA and Health Canada. How many people get there? It's got to be over 35% of people getting there and greater than double the placebo to get the approval. So here we see 62.2% got to 5% at the 4-month range and 18.2%, 10%. At 6 months, you can see that the greater than 10% categorical weight loss doubled. It went from 18.2 to almost 30 to 35.2%. So more patients got to the greater than 10% weight loss when we got to that 6-month time frame. Okay, so what side effects did these patients have? Nausea, 43%. In the clinical trial, it was 44%. That's on par. Constipation was second. In the clinical trials, constipation is about number 3 or 4. For us, it was number 2, and it's somewhat frustrating, but when we talked to the patients, we realized that constipation was something they had previous to coming in. So it just made it a little worse, or continued it, but it didn't stop them from using the actual medication. Okay, what did they say made things better? What did they say was better? Decreased appetite, because that's where it works. It works in the hypothalamus. We expect decreased hunger, decreased appetite. You lose weight, you're going to get hungry. With this medication, you're not supposed to get hungry. That's how it works. But look at number 4, decreased cravings. This is not supposed to be a craving drug, a mesolimbic drug, hedonic system working drug, but these patients said that they had decreased cravings. So clearly, it's working there, and more research needs to go into why and where GLP-1 is in the mesolimbic system. So in our real-world setting, we saw that it was about an 8.1 kilo decrease in weight, so we're 7.1%. So we're getting close to what the clinical trial said. So let's look at the last drug. So Contrave, bupropion. This is the clinical trial. About an 8.1% decrease in weight. So the completers, or the people who liked the medication, stayed on the medication until the end of the trial, which is about 50% of the patients that stayed on it until the end. So the question is will we, in people who are taking the medication, get to that 8.1% decrease in weight? No good real-world evidence study out there. I don't have any as yet because it's been around in Canada for the past year. I need about another 6 months to another year to be able to get some good Contrave data. I'm going to go to this side of the room to continue the rest of it. But there is a real-world study that was done in the States. It's called the IGNITE study. And the IGNITE study, to me, is not a real-world evidence trial. It's not I'm coming to the clinic, I'm deciding to take the medication, and it's cost me money. This was a randomized trial, and the medication was free. But it's not, and it was open label. So it's halfway in between a clinical trial and real-world evidence. But it's all I got to really show you guys to see whether things are coming close. So it's same again. It's usually about 50-year-old women, mainly white, and BMIs were a little lower, about the 36 range as opposed to the 38 or 40 range. So let's see how these patients did. So then we're asking, are they going to get to that 8% decrease in weight, right? Most of the medications on the market that are working well, 8% decrease in weight. So we can see here that in the real world, the blue line is more so the patient starting the medication in the real world, about a 9.4% decrease in weight. So it's if not better or coming close to what we saw in the actual clinical trials. So here we have the conclusions. I'm going to conclude, and I think I'm more than on time. So we're going to have time for some questions. So what I've seen in terms of, are these medications working in the patients that I give them to here in Canada and here in North America? So orlistat is about a 3% placebo subtracted, so about a 6% decrease in weight. But I find that the patients who like it or tolerate it do relatively well on it. They are happy on it. They are rare, right? But they do okay. And I use it more so for the constipation that I talked to you about. So if a person has coverage for Saxenda, they have coverage for Xenical. And if they're having constipation, I oftentimes will give them this medication. They can take it once a day, a couple times a week, and it tends to work out relatively well. So that's literally how I use it. So it's not kind of a joke that I use it for constipation. I actually do use it for constipation. Okay, not myself personally, but my patients. So the question of, and then when we look at liraglutide and the naltrexone bupropion combination, I feel that there's likely a similar impact to what we saw in the rigorous clinical trials. We're getting to that 7-8% decrease in weight. We've seen it in the Canadian real-world data, the LIRA data, and then now the American data that was quasi-real-world evidence. And I'm looking for real-world contrave evidence, and I'm going to be doing that soon. So thank you for your time, and I think we have time for some questions if there are any questions.
Thank you so much, Dr. Wharton. And yes, we do have 5 minutes for questions. So
Oh, great. Thank you very much. Appreciate it.
yeah, it's a long walk to the mic.
Yeah. Thank you very much. I'm a family physician. I work in First Nations community, so my experience with liraglutide is a bit more for management of diabetes. I see with your study, it's like talking over 6 months. I've seen very good experience with liraglutide for the first year or so, but it seems like when I get to about 18, 24 months, my patients start to put back the weight, and I'm just wondering if it's because people don't eat only because of hunger, but for a whole bunch of other reasons. So I'm just wondering if it's something that other people see, that after about 18, 24 months, the liraglutide just doesn't seem to work as well as it used to.
Excellent. So very good point. So the question is are you going to regain weight on these medications? After what period of time do you start to regain? So the bottom line is that all weight management trials, apart from surgery, the maximum amount of weight loss you'll get is at 6 months. So once you get to 6 months, that's it. You're just looking for, can you maintain it? Okay? So that's lifestyle trials and pharmacotherapy trials. In surgical trials, we get to about a year and a half. Once you're at that 1.5 year mark, that's it. That's your weight loss. You're hoping that you maintain it. So there is some degree of let's be as aggressive as we can over the first 6 months because that's all you got. And the question is, why does that happen? Who knows? The brain kind of catches up and goes, what's going on here? This isn't a good idea. I don't care that I'm taking medication or working hard with this ketogenic diet or lifestyle, whatever the case is. I'm going to stop this weight loss at this stage. So at that 6 month mark, maybe other parts of the brain, the mesolimbic part, the hedonic part, the hypothalamus just kicks in and says, no more weight loss happening now. So the bottom line is, are you going to regain weight after that 6 month time frame happens? At a year time, 18 months time? Absolutely. That's the way it works. That's normal physiology, is everybody regains weight. So the only way you're not going to regain weight is if you try to do something different on top of the liraglutide. So what are we doing when people start to regain weight with liraglutide? Because they're going to. So it's not a debate as to whether they're going to. They're going to. So we start combination therapy. We put them either on Contrave, or I send them to Dr. Sandy Van, who does cognitive behavioral therapy. The 3 pillars to weight management are surgery, medication, psychological treatment. The only way to maintain lower calories. Think of lower calories as the roof of a house. You have a roof for your house, it's lower calories. That's the way you lose weight, that's the way you maintain weight loss, is keeping those lower calories. What are going to maintain that roof? The 3 pillars that maintain the house are medication, surgery, and psychological treatment. Nowhere there did I say diet or exercise or other things. Medication, surgery, psychological treatment. You can either use all 3 of them at the same time, or you can change them around, but you've got to use one of those three things to be able to maintain. So we use a lot of the psychological treatment for our patients that are starting to regain weight, starting to plateau, haven't reached their weight loss. And Dr. Van does a lot of our CBT for us, or we introduce another medication on top of it. I switch them from Lira to Ozempic. So that's what I do.
Okay. Thank you, Sean. We have one more question over here.
Hi there. A very nice presentation. I'm Melanie Henderson. I run a pediatric cardiovascular disease risk prevention program in Montreal. And I'm just wondering, I really liked your trick of using orlistat with liraglutide. Do you have any mitigating strategies for the side effects of orlistat, which is the only really approved one in pediatrics?
Right. The only approved one in pediatrics right now
Yes.
is orlistat, and any mitigating to help with the side effect profile. No, the side effect profile is how it works. So there's no way to stop that. It gets rid of fat. So the diarrhea, the anal leakage, the orange stools, that's part of how the medication works. So the only thing that I see is the introduction of new pharmacotherapy, right? So Novo has just finished 3 pediatric studies with liraglutide from age 8 to 18 in a Prader-Willi group and in just a adolescent group. So we're looking to see what the results of those trials are, because pediatric patients need pharmacotherapy. Again, the 3 pillars are surgery, medication, or psychological treatment. So if they're not doing great psychological treatment and keeping the weight off, then they need pharmacotherapy to calm down that part of the brain. Even if that is waking up the executive functioning part of the brain, that's another part too, with ADHD, so that they can calm down the other side, but they need pharmacotherapy. So no real ways to decrease the side effects, but better pharmacotherapy coming.
And just a second little quick question. Do you know what kind of patients actually respond well to orlistat? Can you kind of predict who's going to tolerate it well?
No.
No.
I can't predict anyone who's going to respond to any of the medications at all, ever. I'm really bad at that.
Yeah. So, in the interest of moving along, so we can have our next speaker. Thank you so much, Ron, for that presentation. It was fantastic. So our next speaker is Dr. Priya Manjoo. She's an endocrinologist in Victoria, BC, and the co-director of the Victoria Cardiometabolic Collaborative Clinic, as well as the Victoria Lipid Clinic. Dr. Manjoo is board certified in obesity medicine and is a certified hypertension specialist. The focus of her clinical practice is the management of patients with obesity-related metabolic diseases. So without further ado, Dr. Priya Manjoo.
So I'm going to be using this walking mic, but I'm pretty short, so if I moved back and forth, you wouldn't see me anyway, so I'm just going to stand up here. I'll be talking today about weight management in patients with metabolic complications of obesity. Okay, that's strange. And I'll be building on the presentations done by my colleagues, Dr. Pederson and Dr. Wharton. These are my disclosures. I've done some consulting for companies, mostly in the lipid and diabetes areas, and have received some speaker fees. So we know that obesity is associated with a number of metabolic abnormalities. And in my presentation, we're not going to go through all of these. We're going to focus on some of these metabolic complications. And for each of these conditions, I'm going to be reviewing the weight loss thresholds that are associated with metabolic benefits. We'll also go through the effect of disease-specific pharmacotherapy on weight, and we'll review the evidence pertaining to pharmacotherapy used specifically for weight management in these subgroups of patients. Is there a problem? Oh, what's?
Everybody sees the...
Oh, okay. Okay. Okay, so can everyone see my slides there? Great, perfect. Right, so these are our objectives. So there is a dose-response relationship between weight loss and metabolic complications. And although these vary for each of these conditions, we now have enough evidence to inform specific weight loss targets or weight loss goals for each of these conditions. And this is outlined very nicely in this slide. And we're only going to go through about 4 of these complications, the most prevalent ones: diabetes, prediabetes, hypertension, and fatty liver disease. So in terms of patients with prediabetes, a target weight loss of 3 to 10% has been shown to be very effective in reducing the risk of progression to type 2 diabetes, and in some patients can result in normal glycemia. In fact, a 1 kilogram weight loss on average is associated with a 16% reduction in the risk of developing type 2 diabetes. And this data is actually derived from the Diabetes Prevention Study, which was a randomized controlled clinical trial that was conducted in about 3,000 persons with prediabetes. They were randomly assigned to intensive lifestyle intervention, metformin, or placebo, and they were followed for 5 years. And the patients in the intensive lifestyle group had a 58% reduction in the risk of progressing to type 2 diabetes. Now, this is a fairly robust study and resulted in numbers needed to treat that were actually very favorable. However, after the end of the DPP trial, patients were followed in a prospective outcomes trial called the DPP outcomes trial. And it was done to determine if this relatively, it was done to determine whether or not the relatively short-term benefits of delaying the onset of diabetes would actually translate into long-term impact. And so what this showed was specifically among the patients in the DPP study who had lost at least 5% in the first year, those who were randomized to metformin and continued on metformin actually had a, they actually showed the greatest weight loss maintenance in the following 5 to 14 years. And this was really important because you look at the lifestyle intervention group and the effects of the intervention waned over time. And to me, this underscores the importance of pharmacotherapy, and this is something that Dr. Pederson and Dr. Wharton emphasized in their presentations, and this is just another example of the importance of pharmacotherapy in the management of obesity. So in terms of obesity pharmacotherapy that's specific to patients with prediabetes, we have data for both orlistat and liraglutide, and of course the data is more robust for liraglutide. So in terms of patients with type 2 diabetes, we know that obesity in patients with type 2 diabetes is associated with a poorer prognosis. There's poorer glycemic control, higher blood pressures, and less favorable lipid profiles compared to patients with type 2 diabetes who do not have obesity. And so weight management in this population can have beneficial effects, not just on glycemic control, but it can increase the chances for these patients to get to target with other metabolic parameters as well. So in approaching weight management in patients with type 2 diabetes, even a modest weight loss of 5 to 10% has been shown to be associated with improvement in several metabolic parameters. And we have so many agents now that are available for the management of type 2 diabetes that when we are in a position to select pharmacotherapy for managing patients, for getting patients to target with their A1C, we actually have an opportunity to choose agents that can optimize weight management. Now, it's not simply just sort of choosing the medication with the greatest weight loss. I wish it were that simple, but it's not. All patients are different, and it's really important to be able to sort of balance these factors, not just the effect of the medications on weight, but also the intensity of the lifestyle interventions that patients are going to be undertaking, and the patient factors, their preferences, the cost of medications, and the duration and severity of diabetes. But we can also choose to treat patients with diabetes with pharmacotherapy that is specific that's specifically indicated for weight management. And there is data supporting the use of orlistat, liraglutide, and Contrave, naltrexone, bupropion in these patient populations. But only liraglutide has the dual indication for treating both glycemia and weight. Orlistat and naltrexone, bupropion can be used for weight management, but they should not be used solely to reduce A1C. So we'll switch gears now to patients with hypertension. So among patients with hypertension, again, very modest reductions in weight have been associated with beneficial effects on blood pressure. on average, each 1 kilogram reduction in weight is associated with a 1 millimeter of mercury reduction in systolic and diastolic blood pressure. And in fact, there is such a robust relationship between, such a robust dose-response relationship between weight loss and blood pressure reduction that even reductions in weight above 15% are associated with blood pressures that are still dropping. And this data comes from a meta-analysis of 25 RCTs that enrolled about 5,000 participants from different ethnic populations. And what was really striking about this is not just the blood pressure reductions with weight, but also the fact that larger blood pressure reductions were achieved in patients with antihypertensive therapy on board. The weight loss was associated with larger reductions in blood pressure in Asian versus white or black populations, and the blood pressure response to weight loss was independent of the initial BMI, gender, and the type of interventions that the patient was undergoing. What's more important is that weight loss was associated with improvements in end organ damage independent of the blood pressure lowering. So weight loss reduced urine ACR. It was associated with a regression in left ventricular hypertrophy. And all of these things just underscore the importance of weight loss, of lifestyle modification to reduce body weight as a major component of hypertension management. So there are not many guidelines or documents that address the management of hypertension in patients with obesity. In 2013, the European Society of Hypertension and the European Society of Cardiology put out a document in which they sort of published a review on hypertension and obesity. And they recommended a very flexible approach to the choice of pharmacotherapy, which would take into account the patient's risk factors and the effect of these medications. So in general, diuretics, RAS inhibitors, and beta blockers were cited as reasonable choices for hypertension management. They discussed some of the limitations associated with each of these medications and recommended that these be considered when you are managing patients. Diuretics, for example, can have the potential to worsen glycemia and gout. Beta blockers can have potentially negative effects on glucose metabolism and weight, particularly in younger patients with obesity who don't have the renal complications that would be stronger indications for these medications. And agents like calcium channel blockers are more likely to cause peripheral edema in patients with obesity compared with lean patients. In terms of pharmacotherapy for weight management in patients with hypertension, both orlistat and liraglutide produced fairly modest reductions in blood pressure, and this seems to be very much related to the amount of weight loss that was produced. Dr. Pederson talked a bit about the association of naltrexone and hypertension, and I'll just sort of reiterate again that the clinical trials suggest that naltrexone bupropion attenuates the blood pressure lowering effect of weight loss, and I think that's very important. So it shouldn't be used in patients who have uncontrolled hypertension, and if someone is on hypertensive therapy, you may need to monitor them a little bit more closely. The last complication that we'll talk about is non-alcoholic fatty liver disease, or NASH. And we'll sort of start off first by clarifying some of the terminology. So fatty liver disease is the replacement of the hepatocyte cytoplasm by fatty tissue, and that's known as macrovesicular steatosis. Non-alcoholic fatty liver disease is that steatosis that's not caused by alcohol use. And NASH, or alcoholic steatohepatitis, is steatosis with evidence of inflammation or liver damage. So the steatohepatitis is a more severe form of disease. NASH is actually more common at BMIs greater than 35. The cirrhosis is more common in patients with obesity compared with patients without obesity. And we've got very good evidence that the weight loss goal of 3 to 5% is associated with improvements in steatosis, and 7 to 10% is actually associated with improvements in inflammation. This is a very important slide, and it's important because I think we underdiagnose NASH in a lot of our patients. You can't treat NASH and you can't have an informed discussion about weight loss targets if you don't know that the patient has this complication. So because patients with very high levels of fibrosis or high or advanced degrees of fibrosis still have relatively preserved liver function, you can actually have fibrosis in a patient with normal liver function tests and not be aware of the fibrosis. When you get to a certain point, around 60 to 80% fibrosis in the liver, liver function starts falling off fairly quickly, and then the progression is very rapid. And so you lose the opportunity to intervene in these patients. So there are ways of assessing the risk of NASH. Non-invasive techniques like the FibroScan or shear wave elastography is one of these mechanisms. And this should be used in patients with diabetes, patients with obesity, and those with uncontrolled hypertriglyceridemia, even if the liver function tests are not elevated. I don't use the scoring systems, the APRIs, or the NAFL scoring systems in these patients. I send a large proportion of my patients for non-invasive testing, specifically because we don't want to miss this, or we want to pick it up much earlier than we do. In terms of the pharmacotherapy for NASH, orlistat has no demonstrated benefit. Liraglutide is the agent with the most benefit demonstrated in this patient population, and it's been associated with a 39% reduction, or a 30% reduction, or rather a 30% rate of resolution of NASH. Naltrexone has not been studied in this population, but there is some interest in the anti-inflammatory effects of bupropion. And there have also been some small studies that have suggested that metformin metformin can be associated with a small decrease in BMI, and that can translate to improvements in aminotransferases or even liver pathology. So most patients with NAFL are not going to have chronic liver disease complications. Most of them are going to have chronic metabolic disease. And the leading causes of death in patients with fatty liver disease are cancer and heart disease. But it's very important to select those patients with advanced fibrosis, offer them pharmacotherapy, and monitor them for liver-related complications, repeating testing, and really consider referring this patient population to gastroenterologists. So I'm going to stop there at 15 minutes because no one here thought that I could actually finish this in 15 minutes. So I left lots of time for questions. Great. Perfect. Great. Perfect.
Thank you so much. So question time?
Yeah.
We have lots of time for questions.
5 minutes, people. 5 minutes for questions.
Well, it's just a break after this, too.
Yeah.
So if we do have, does anyone have any questions for any of the speakers? 'Cause I think they're all here.
Yes.
So how do you diagnose
Okay. So there are a couple of different ways. Oh,
Did
sorry.
everyone hear the question?
Oh,
It's how do
sorry.
you
So the-
diagnose NAFLD and NASH?
Yeah. So there are two schools of thoughts. You can use risk scoring engines like the APRI, the FIB4 test, and the NAFLD scoring system to identify patients with a higher or lower probability of NASH. And I think those scoring systems have a better negative predictive value. Sorry, they have a higher positive predictive value, but they'll still miss a lot of cases. So in patients who are high risk, like the ones that I mentioned, patients with obesity, with diabetes, with hypertriglyceridemia, with several components of the metabolic syndrome, I tend to send them for imaging, ultrasound imaging, and also for shear wave elastography, which is becoming more and more available. It's non-invasive, it takes 5 to 10 minutes, and it gives you a lot of information. It tells you the degree of fibrosis in those patients, and it often doesn't correspond with the clinical scoring systems. So that's how I diagnose this. And you have stage 0, 1, 2, 3. Stage 2 patients are actually considered to be more advanced, and those are the patients that should probably see a hepatologist. Yep.
Liver function tests at all?
I do if the liver function tests are elevated. Sometimes patients are on concomitant medications that can affect their liver function tests. Some statins are inducers of transaminases, and so you can see increases in liver function tests transiently when you start statins. So I do follow that. But in the patients that do have high liver function tests related to NASH or fatty liver disease, you can see them decreasing very nicely as patients lose weight. Yeah.
Last question.
Yeah.
Do you follow all liver function tests or just ALT? What do you follow?
Yeah. So I'm wishing that Dr. Cruz Pereira, my hepatology colleague, was here to answer those questions. But I tend to follow the ALT and the AST. Just because those are tests that are very quick, they're very easy, they're part of our panels, and I don't want to be doing more extended liver function tests on everyone. But in those patients with more advanced fibrosis, they will look at other parameters. Thank you. You're welcome. Any other questions? Yes.
This room's meant for exercise.
Yeah.
Yeah. Hi, Priya.
Hi.
Michael Lyon. In our high-volume obesity medicine practice, we administer an age questionnaire to every patient, and no one has alcohol use disorder. Essentially, nobody wants to talk about that at our clinic. But interestingly, when I have brought up the new knowledge to patients that there are now drugs available to help people reduce their alcohol cravings, it seems like 1 in 3 have an alcohol use disorder all of a sudden magically. So I wonder, when we use the term non-alcoholic fatty liver disease, if we're referring to a lot of people who actually have some alcohol use disorder, and that of course would confound the treatment, and it would also be something that I guess the patient maybe would not be quite as aware that combining obesity and alcohol and then lots of Tylenol for their hangovers perhaps together might be something that is more of a concern than we realize.
Yeah, absolutely. And I think when you see patients with high liver function tests, you cannot assume that it's NASH. You actually, if the liver function tests are normal, then I don't usually go on to look for other potential causes. But if the liver function tests are high, then I start looking for fatty liver. I start looking for alcohol use as a potential contributor. We look for hepatitis, autoimmune disorders of the liver. So, and that's sort of the strategy. But just in those patients, you can't do that testing on everyone. You've got to be selective in who you choose. And it's usually the patients with the higher liver function tests. Yep. Yeah.
Go ahead.
My name is Nicole Gagnon. I work at the Royal Ottawa Mental Health Centre. I actually have a question for Sean Wharton.
Yes.
Just wondering if you've done any studies with metformin.
Oh yeah, studies with metformin. We did a CAMH study, so it was a study looking at patients on psychiatric meds, and it's not published yet, but it's showing relatively similar data to what we saw with the meta-analysis. So there's a meta-analysis that came out, is it 2 years ago, or is it last? 3 years ago? So showing that all the small research studies put together with metformin, people on psych meds, what it showed was that if you start the metformin early, you can get about a 6 kilo decrease in weight. If you start it later, after they started the psych meds, they've been on it for 6 months or a year or such, then the weight loss is a little bit smaller. But certainly for a lot of our patients on psychiatric meds, that's one of our first go-tos, and it seems to help with a lot of the metabolic conditions apart from the blood glucose.
So is that a 6 kilo actual weight loss or prevention and weight gain?
So it was a weight loss. That's what I... Prevention of 6 kilos?
Yeah.
Okay.
Okay.
Thank you.
Okay, good, thank you. Thank you.
Hi there. My name's Emily. I'm a dietitian in Ontario Shores Centre for Mental Health Sciences. I work in a metabolic clinic. Just wondering if you guys have any experience with binge eating disorder and Vyvanse. Do you have any?
With what?
Binging disorder? Binging disorder, you said?
Yeah, binge eating disorder and Vyvanse.
Who wants to take that one?
Do you want to take that?
Good. Sean?
Yep,
Go ahead.
go ahead.
Okay.
So the whole binge eating disorder and Vyvanse and the obesity field is a little bit challenging because the Shire, the company, and a lot of the binge eating disorder companies are not connecting it with obesity. And so we don't do a whole lot of work in that field. They're trying to deal with the binge eating disorder itself, trying to make that executive functioning part of the brain more of an awake brain, starting to stop all the noise that is happening so the binge eating disorder can actually be attenuated. But that doesn't necessarily always have to be connected to a decrease in weight. So I think that the connection is that, because we've talked to them a couple of times, and it's like we're not connecting this with obesity and weight loss. We're just connecting it with getting your binge eating disorder under control. If that equals weight loss, fine. If it doesn't equal weight loss, fine. But at least the binge eating disorder is better than it was previously. So that's where we're currently at. I do use it, but I don't necessarily use it expecting weight loss to happen. I just want their binge eating disorder to get better. The weight loss happens because of all the other things that we talked about. But maybe Sue has a point as well.
Okay. So just a reminder for everyone to fill out your evaluations. Are there any, I think we could, no more questions? No more sprinting to the microphone? Okay. Thank you to all our speakers for a wonderful presentation. And judging by the full room, it was clearly an important one. Thank you. Lisa?